It is 10 o'clock and it is time to start the webinar. My name is Hanne Ørnsted Hansen and I'm a coordinator at the Danish Diabetes Academy. Welcome to all of you. We are delighted that you have joined our webinar with Professor David McIntyre, who is joining us from Australia. And thank you to Professor David McIntyre for accepting to speak at this webinar. We really appreciate it. And also thank you to Professor Per Ovesen for accepting to give a brief insight into the situation in Denmark. Just a few practicalities before the presentation starts. Professor McIntyre have prepared a presentation of approximately 25 minutes. And afterwards, and that leaves time for questions and discussion. If you have a question or want a comment, please use the chat function, which you find in the bottom right corner of your screen. You can either write your question, or if you will want to ask your question verbally, write something like, I have a question or something similar, then I will unmute you. And please write your question to all participants, or it might say everyone. That was all from me. Now, Professor Per Ovesen will give a brief insight into the situation in Denmark. So, Per, you are unmuted and should be able to speak. Welcome.
Yes, thank you. Thank you. Today's webinar is on the topic of pregnant women with diabetes and COVID-19 pandemic. Since March, all Danish maternity wards have reported information on all pregnant women with verified COVID-19 infection to a common database. And from March to the end of August, there has been 148 pregnant women with COVID-19 in Denmark. 6 of these were hospitalized due to COVID-19 symptoms. The rest were uncomplicated, and there has been no maternal or infant death. Then I have contacted all the larger hospitals in Denmark, Aalborg, Odense, and Copenhagen, and asked them if they have had any women with pregnant women with diabetes and who were infected with COVID-19. And none of us have had any patients infected with COVID-19. Then I asked about the diagnosis of gestational diabetes, and we haven't changed any circumstances regarding the diagnosis of GDM, besides more space in the waiting room. So it doesn't seem there's the COVID-19 is a large problem for women with diabetes, pregnant women with diabetes in Denmark. This summer, I met a pregnant woman with diabetes in my clinic, and I was the first person, besides her husband, she had met in real life for 2.5 months. She has been totally isolated because she was so afraid of being infected with the coronavirus. Maybe today's lecture can tell us how scared you have to be to get COVID-19 when you are pregnant and have diabetes. And today's lecture is Professor David McIntyre from Brisbane, Australia. And Professor David McIntyre is an endocrinologist specialized in obstetric medicine. And he is well-known and admired leader in the field of diabetes and pregnancy. He is a visiting professor granted by the Danish Diabetes Academy, and furthermore, he holds an honorary scholar professorship at Aarhus University since 2019. So welcome, David. I'm looking forward to your lecture.
Thank you, Per Ovesen. And David, now I will unmute you and you should be able to share your presentation.
Just let me get that. Yep, there we are. Okay.
Good, fine.
That seems to be working. It's blanket, but I'll go to the first slide. Does that look better?
That looks better, yes, thank you.
Yep.
Okay, thank you very much. Well, welcome to everyone, and I can't see you, but I know that you're there somewhere in the internet for the virtual universe. And thanks, Per, for your kind introduction. And these are my affiliations. And as Per noted, I'm very honoured to be a Scholar Professor in Diabetes and Pregnancy at Aarhus, and also attempting to visit at least Professor of the Danish Diabetes Academy. So this story started in 2017. And it was really a question of an old dog coming to Copenhagen and to Denmark in general to learn some new tricks. And that's what I hope it will continue to be in the future. So COVID-19 and GDM, how do they go on a worldwide basis? And in fact, the coincidence, as Per has outlined, is not such a big issue for either Denmark or Australia. So Australia sits in a somewhat higher GDM region than does Denmark, with prevalence around the 13 to 15% mark, as opposed to perhaps 6 to 8%. And fortunately, both of us are probably relatively lower in the GDM prevalence, although Europe, of course, as we know, is very much affected in many other countries by COVID. But I guess one of the big points from this slide is there's a lot of parts of the world with fairly poor healthcare resources, such as, for instance, the Indian subcontinent, South America, which are hit by the dual whammy of both high prevalence of GDM and high prevalence of COVID. And so in those areas, it's probably a more pressing issue. The other thing that has been obvious to all of us is that the COVID situation really changes so incredibly rapidly, almost, in fact, sometimes on a daily basis. And things have really evolved very rapidly since the beginning of the epidemic, hitting Australia, at least in around March this year. So we really have to keep up on a near daily basis on what's going on. So I wanted to talk a little bit about COVID-19 and pregnancy in general, and then about one of the biggest issues, which is that of the glucose tolerance test and the unattractive idea of having a 2 to 3 hour test in the midst of a pandemic, which has led to several changes in testing in various countries, and also thinking about other ways of avoiding COVID-19 exposure. And then I think there's the general question of where healthcare resources have been diverted in the midst of a pandemic. In some places, many of these have had to go to the COVID response, and some other areas of chronic healthcare in particular have been neglected. And very rapid changes have certainly happened here in Australia in terms of use of telehealth and telephone consultation. Things that seemed impossible 6 months ago are now routine in our clinics. And there's also the whole question about postnatal care and postnatal follow-up. And then I think underlying this, there's the question of the relative perceived value of the acute infectious disease crisis versus the long-term risks of non-communicable disease, in particular for women and their children with GDM carrying longer-term risks of diabetes, obesity, and perhaps cardiovascular disease. So there has been that whole conflict of short versus long-term healthcare priorities. Now, very early in the piece, FIGO actually launched this global interim guidance, which was really a response to a lack of information regarding COVID. And it drew largely on experience from places like Hong Kong and mainland China and also Italy, where there had been early experience with large numbers of cases. And in those centres, there'd been some experience with the more severe end of COVID infection during pregnancy. But I'll just point out that in terms of what I'm speaking about today, there were no suggested changes to COVID-19 related GDM diagnosis in that FIGO document. However, shortly thereafter, there were some changes suggested to GDM. So I think we all know that the approach to the diagnosis of GDM varies very widely around the world. We have had these supposedly international suggestions from IDPSG and then the World Health Organization about using universal 2-hour glucose tolerance testing. I point out that in many countries, for instance, in China, there's quite a different approach. They're already using fasting glucose screening at that first antenatal visit, and also often using a fasting glucose test to decide on whether a full glucose tolerance test is necessary at 24 to 28 weeks. In Denmark, as you know, risk factors are used to decide on both early and standard GDM testing, and Denmark generally uses a single 2-hour glucose value on the GTT of greater than or equal to 9 millimoles to determine GDM diagnosis. The UK has yet another different process, screening by risk factors, using rather different and higher fast glucose and lower 2-hour glucose criteria than many parts of the world. And they potentially test both early and late in pregnancy, but only for those with risk factors. So then some of the early places to move and to suggest major changes in their GDM screening and testing protocols are listed on this slide. So in the UK, the post-COVID testing was still recommended to be risk factor based, but they went to a situation where they totally avoided recommending glucose tolerance tests and recommended HbA1c and either a random, perhaps preferably a fasting glucose for their GDM diagnosis. And they came up with somewhat different criteria. So the fasting criteria the same, the random somewhat higher than they've been using for other criteria, and also inserting an HbA1c value in there as a potential way of testing for GDM. Now, Canada had been using 2-step testing with the glucose challenge test, followed by a glucose tolerance test, and had been using cutoffs which included a fasting, but in fact the 2-hour value set at the odds ratio for 2.0 from the IDPSG, which is obviously the same as what Denmark uses, but using only the fasting, only the 2-hour rather than the fasting. Now, post-COVID, they moved to still a universal form of testing, but without any glucose tolerance test, using HbA1c and random glucose only. And these were the cutoffs they suggested, 5.7% for HbA1c. Random glucose really set very high at 11.1 millimoles per litre. Now, Australia came up with yet another different approach. Australia has been using universal testing with a 75-gram glucose tolerance test and using the IDPSG WHO 2013 criteria at the odds ratio of 1.5. And post-COVID, it's still recommended largely universal testing, but has recommended this stage protocol with the fasting glucose being used to rule in or rule out GDM. So if the fasting glucose is greater than or equal to 5.1, that's considered GDM. If the fasting is in this intermediate range, and it's only in this group that a glucose tolerance test is required, and then fasting less than 4.7 is accepted as normal, with the acknowledgement that it will miss some women with GDM. So we wanted to then examine what this meant in terms of the number of reduced number of diagnoses, but also in terms of how many outcomes were potentially missed or detected by each diagnostic approach. So in collaboration with a number of other HARPO colleagues from 5 different centres, we collected a HARPO cohort of almost 6,000 women. And these women all had a full 3-hour diagnostic glucose tolerance test and HbA1c. And the glucose was blinded. It was a HARPO study, so there was no treatment for GDM. And we were then able to compare the UK, Canadian and Australian approaches, both pre and post-COVID, in terms of the number of women picked up with GDM and the number of pregnancy outcomes which may have been influenced by treatment, which would be missed by these differing approaches. And to cut to the beginning of a long story short, this is what we saw at baseline in green and post-COVID in blue. So you'll see that even at baseline, the Australian approach with its lower cutoffs and universal testing is classifying something like 17% of women as having GDM. That rate is much lower in Canada, with about 9.3% of women being detected, and in the UK, in the middle, with 12.9% of women classified as GDM. Now, Denmark, I imagine, will be somewhere around the Canadian experience, but not using the fasting would lower that number somewhat. And then post-COVID, with the new suggested protocols, in both the UK and Canada, their GDM detection rates would fall by about 80% to 2.5% and 1.5% prevalences respectively. And in Australia, the GDM rate would fall by about 25% from 17 to 12.7%. But you see that even in the post graph, Australia would still be picking up more women and classifying them as having GDM than Canada was in the pre-COVID world. So these, got to remember that both the baselines and the post-COVID protocols are quite different. So what then are the consequences in terms of clinical outcomes? And to deal with this country by country, this graph shows what the outcome frequencies of hypertension, preterm birth, LGA, excess neonatal adiposity, and primary cesarean section were in non-GDM women. And you'll see in this case, the post-COVID women in the UK who are still classified as GDM with the revised testing approach still do carry a substantially higher risk than the other groups, but the risks of things like LGA are still approaching 15% in the missed GDMs, and the outcomes nonetheless are a little bit more severe in those who are still classified as GDM with the post-COVID approach. Now, looking at this another way, this is the percentage of total outcomes amongst GDM women that are missed by the post-COVID approach. Now, obviously, things like LGA, preterm birth, etc., are not specific for GDM. So, in fact, many of these outcomes will occur in women who are not classified as GDM. But around about 80% of outcomes previously attributed to GDM are missed by this UK approach. So that needs to be taken into consideration. Now, for Canada, interestingly, this is the non-GDM rates, and this is the post-COVID and the missed GDMs. You will see that, in fact, the women that they're excluding from diagnosis in Canada in the post-COVID space, these are the ones in the blue bars, actually carry a very similar risk to the women they are still classifying as GDM in the post-COVID space. So, in fact, their way of discriminating women leads to exclusion of a group of women who carry almost the same risks as those they're continuing to consider as GDM. And this is perhaps even more striking here, where you see that the post-COVID GDMs and the missed GDMs very similar outcome rates, and the percentage of outcomes missed overall is around 80% across the board. So they're getting their their GDM numbers down, but they're also missing a very large percentage of outcomes. Now, the pattern in Australia is somewhat different. These are the GDM outcomes as noted. And in fact, you'll see that the post-COVID GDMs, as in the English case, are still at much higher risk. But in fact, the missed GDMs carry only a slightly higher risk than those classified as normal. In fact, for hypertension, they're actually less likely to have hypertensive complications in pregnancy. For LGA, yes, their results are a little bit higher in terms of LGA prevalence, but still only around the expected 10% for LGA and neonatal adiposity. So the Australian approach reduces the numbers of women, but less dramatically than the others, and the missed GDMs only miss around about the 15 to 20% mark of total outcomes. So this is not to say that any one of these approaches is right or wrong, and in the end in Australia we've been fortunate to have very low rates of COVID, so it hasn't been such an issue, but it just does go to show how different the changes are between various countries. And in terms of those percentage of outcomes missed across the three countries, this is the UK in blue, Canada in red, Australia in green. You see that the percentage of outcomes missed is highest across the board in Canada, second in the UK, third in Australia. So this is the cost of these changes in terms of GDM outcomes missed. Now, since then, there have been a number of other approaches for which full data. Spain has suggested using HbA1c, also possibly random or fasting glucose. Italy has come up with using fasting glucose only, and France has suggested a possibility of fasting glucose plus HbA1c. Now, interestingly, in the idea of testing in early pregnancy, there's been much less evidence, but people have been able to agree more. So it's one of those cases in which evidence does not necessarily help consensus. And most people have gone for risk factor-based testing, using an HbA1c greater than or equal to 6.5% to define overt or diabetes in pregnancy, and 5.9 to 6.4 often being used in early pregnancy to define a GDM equivalent, with some including other options. So there's then this paper by David Simmons, which has quite nicely outlined what this means in terms of actual exposure time. And in terms of testing time, clearly the full glucose tolerance test for all takes a bit over 2 hours. If you shorten that to a 1 hour glucose tolerance, clearly your exposure time in pathology collection is less, and you miss around 12% of GDM. If you do only a fasting glucose, well, it's a much shorter testing time, but you have to arrive in the early morning. We'll miss something around 20 to 25% of GDM, and that number will depend on the ethnicity of the population you're testing. Now, by contrast, HbA1c is obviously a quick test, a random test anytime during the day, but we'll miss around 75% of GDM diagnoses. That will vary according to various red cell abnormalities and red cell lifespan, also ethnicity and iron status. And I'll just point out that the cutoff that people have recommended of 5.7% actually in the HARPO data is around the 99th centile of HbA1c. So you're not going to diagnose very many of your population with GDM using that HbA1c cutoff. If we go then to random glucose, some people have suggested this as an alternative. It probably misses around 30% if you set a 7.5 millimole cutoff, and that will be worse if you use a non-standardized home meter rather than a laboratory meter. Now, some people have also suggested that you would just take a previous diagnosis of GDM as being equivalent to GDM in the current pregnancy. And the problem with that approach is that GDM recurrence actually only averages around 50% and varies quite a bit again by ethnicity. And some people have suggested you could forget about diagnostic testing and just give women home capillary meters and do no laboratory testing. But of course, that means that women who are not have GDM are tested with as GDM, and there's really no evidence around that protocol. So just some other aspects briefly of care during pregnancy. What we have found in Australia is that people have very enthusiastically adopted digital health, web-based solutions, telehealth, telephone consultations. And of course, the glucose tolerance test is not the only time you could potentially be exposed to COVID, and people have, in the very beginning in Australia, said they were very unwilling to come to a hospital or anything resembling a hospital because of their own risk of being exposed to COVID. And there are a lot of other things you can do, of course, to stop yourself getting COVID, apart from avoiding a glucose tolerance test. I think one of the important things that's been missing is this care after pregnancy. So a lot of recommendations have just said delay testing for glucose tolerance after the GDM till after the pandemic, whenever that might be. Clearly, high-risk women, the rare ones who you think clinically may actually have type 1 or type 2 rather than just standard GDM, they need early and appropriate follow-up. And I think we have had very little consideration regarding this whole issue of future health of the mother and future health of the baby. So in summary then, there have been multiple approaches to GDM detection during COVID. They're really done on a very thin evidence base and totally empirical. I'm sure everyone has had good intentions, but most of these decisions have been made very quickly in response to pressing demands and in an anxiety and fear-laden atmosphere. So I think whatever we do now, we need to assess and audit whether these diagnostic and therapeutic changes are actually working, and we need to balance current and future health risks. And we need to decide whether those changes during COVID should or would or might affect the future way we deal with GDM diagnosis and care. Now, I'd then like to just move on to talk about my projects in Denmark, and there's a number of these, and I'm still hoping to actually eventually make it physically to Denmark, of course, to do some of these, but my current fellowship with the Danish Diabetes Academy is with Per, based in Aarhus, but certainly planning to visit again Aarhus, Odense and Copenhagen, as I have in the past, and this has been virtual participation in a COVID-laden world. And these are some of the projects I've been involved with. I'm going to talk a little bit about Sugar Mum and GDM diagnosis and risk modelling, but also I've been very happy to be included in the investigators for the pregnancy and bariatric surgery study run out of Odense, for Ulla Kampmann's study of resistance in pregnancy and after pregnancy, to have something to do with FACEIT, which I think is a very important study of post-GDM care, and to have some advisory roles in the DIP register, to be included as an investigator in the COPE and FAST study and in some of the ongoing Odense child cohort analyses. So this paper was probably one that made a bit of impact in my last stay. We had this publication in Diabetes Care from the Odense child cohort about GDM diagnosis in Denmark. And you may recall, those of you who've read this paper, that the fasting glucose in Odense was much higher than in the HARPO cohort, in fact, around 5 millimoles mean rather than 4.5, which would have led to 40% of these Danish women being diagnosed as GDM on the fasting glucose alone, which was clearly impractical. Now, interestingly, there's been a few follow-up reports looking at some of the analytic aspects. This study from Melbourne looked at the use of fluoride citrate tubes, which are used in the Odense child cohort, and they perhaps gave some explanation in that that study reported fasting glucose could be 0.4 to 0.5 millimoles higher. So this may explain a degree of the variation we saw in Odense. There's another study from Canberra in Australia looking at the treatment of samples early post-venesection and found that early centrifugation was very important. There's a study recently published in Diabetes Care which suggested as a practical thing, if you're collecting in a fluoride citrate tube, you should subtract 0.2 millimoles from the glucose value to allow comparison with the HARPO methodology. And this might seem like a very small difference in glucose, but 0.2 millimoles actually leads to a doubling or a halving of your GDM prevalence, depending on whether it's a positive or a negative bias in the laboratory. So what did this all mean? And initially we were trying to say that there might be some sort of Viking gene that allowed Danes to run at a higher glucose, or maybe it was just lab-to-lab differences. I think that's still something that's open for debate and discussion. Now, just briefly to talk about Katrien Scheuer's PhD program. So this is a study which has been running for some time in Hero. I hope I said that even vaguely right, with Tina Clausen, and I've been happy to be part of that. And it just outlines again the differences between the WHO screening, the selective screening you have in Denmark, and the differing protocols. And I think this will be an important study. Again, it's had a little bit of trouble with recruitment due to the COVID-19 pandemic and to changes in hospital attendance. But the idea is to collect all of these baseline features, to realise that most of these women won't be treated under current Danish criteria, to do a full diagnostic GTT, growth scans, postpartum data, and to try and develop the best predictive model to help diagnose GDM in Denmark. And I look forward to further data collection and the results of that study. So what we're really trying to do across all of these places is to balance risks and benefits. And clearly one of the major ones, we're balancing the exposure to COVID and what happens to women and their babies in terms of pregnancy and later outcomes. So that's what I'd like to discuss further tonight, perhaps not so much the COVID issues as how to achieve this delicate balance. Now, because I was pining for Aarhus tonight, I checked the weather report today. It looks like today is actually a pretty good day at Aarhus, but the weekend looks more like typical Aarhus weather heading into winter. And just to make you slightly jealous at this time of year, I'll show you a couple of pictures from Nusa, where I plan to head tomorrow. And with that, I'll thank you for your attention and look forward to some discussion around my presentation and other issues. Thank you very much.
Thank you, David, for your presentation. And we also hope that you soon will be able to travel to Denmark again. And yes, the weather here in Odense, where I am, it's sunny but cold. So we are ready for questions and comments. Please use the chat function, which you find in the bottom right corner of your screen. And if you want to write your question verbally, just write, "I have a question," or something similar, then I will unmute you. Yes, Felix Wittström wants to be unmuted. Just one minute. Felix, you are unmuted and should be able to ask your question.
Hi, can you hear me?
Yes, I can. Welcome.
Yes. Thank you very much. Thank you so much, David, for the presentation. Very interesting to hear. I'm sitting actually in Aarhus at the Department of Clinical Epidemiology and planning some studies about GDM. And just from your presentation, I was of your latest study about missed GDM cases. I was wondering, maybe you said it, but and maybe I didn't catch it, but how did you define missed GDM? I mean, you had in all your graphs displayed how many missed GDM cases there were in each country.
Yes, so that was defined compared to the number of cases in the country on their pre-COVID testing. So they're all different.
Okay.
So they all had a certain number that they were happy to classify as GDM in the pre-COVID specifications, and those numbers are all different because they're all using different criteria. Then if we applied their post-COVID criteria, now we did have to make a couple of assumptions. For instance, we had to assume that there would actually be universal testing in the UK. But then just applying the numbers that they were using, both in terms of HbA1c and glucose, to their samples from Harpo, we were able to work out how many would still be called GDM if they used universal testing in their post-COVID recommendations. But there are some caveats there in terms of the fact that they're not all recommending universal testing.
Okay, thank you.
Thank you for your question. And we are, of course, hoping for further questions. Professor McIntyre, if you, yes, there's one more here. I have a question that is just some questions that only I can see. I will just post them for everyone to see. This is a question from Dorte Müller Jensen. David, can you see it?
I can't, no.
No, it's in the chat function.
It's in the chat now.
Says, thank you for a very interesting talk, David. Do you think we will ever return to pre-COVID routines regarding OGTTs? Will you be doing economic analysis on the HAPO data?
Yeah, so thanks, Dorte. Well, I mean, Australia, it's going to be a bit hard to put the genie back in the bottle. I mean, I'll tell you, the pregnant women themselves love the idea of not everyone having to have TT. So if you look at the Australian protocol, about 50% or 50 to 60% of women have a fasting glucose under 4.5, or take it a bit higher to 4.7. It's more like 60, 70%. Another, 8% might be diagnosed as GDM. So that leaves GTTs only for 20 to 30% of the population, which women are very happy about and their GPs are very happy about. So then saying again that everyone has to go back to having a routine full glucose tolerance first of all is going to be difficult. So Harpo itself hasn't really done the economic analyses, but other people have. I mean, the UK has tried to do this, and I think they got themselves into a bit of a mess by trying to do that. But it's probably better to apply the economic analyses, I think, to the treatment studies. But it is an interesting point in terms of depends how you cost something. So the UK decided that they could not allocate a cost, for instance, to large for gestational age or excess fetal adiposity. They really only allocated costs for things that related to hospitalisation, like caesarean section, preterm birth, and admission to NICU.
Yes, and then Helle Terkelsen have asked to be unmuted, so I will unmute Helle now. Helle, you are unmuted and you should be able to ask your question.
Yes, thank you very much. Thank you, David, for a very interesting talk. It's Helle here from the FACEIT study and from also from STCC and Aarhus University. According to the FACEIT study, which is, for those of you who don't know, a post-GDM trial where we seek to try different behavioral or health promotion interventions. David, have you already been discussing with Per, Dorte, and others about whether do we have a different population in our trial during this COVID period, or do we still have the same population, basically?
My understanding is, I mean, I think if you have GDM in Denmark, there's no doubt that you absolutely definitely have GDM because you're only generally with other risks and you're using a relatively high cutoff. So I think there's no doubt in a positive sense that a Danish woman diagnosed with GDM definitely has a problem, or potential problem, both in the pregnancy and with follow-up. And I think you haven't actually changed your testing procedures from what Per was saying. And given that it's a fairly simple test, and well accepted, there's probably no reason to do that at this point. So I don't think your risk profile will change, and hopefully that won't bias the results of FACEIT in any way.
Okay, thank you. So maybe there will be some women not showing up as much as they should have done, but you think basically it would be the same population?
I think, yeah, there might be some women who don't turn up for their testing, but
Yeah.
but I think generally the overall things will be much the same.
Thank you very much. Good to hear.
Thank you, Helle. I will mute you again. And then...
I can see one on the chat, is that right?
Yes, if you can see a question, please.
It was about the timing of the HbA1c. So when was the timing of, what was the timing of the not promising HbA1c? It was a pretty lousy predictor. Well, I think that is generally true. HbA1c, we'd like it to be really good, but it's really poor as a predictor. It just does not change quickly enough or with a high enough slope to be, discriminating between one group of women and another. So in the HARPO study, the HbA1c was taken at the time of the glucose tolerance test effect on the same day, and they were all processed in a standardised way in the central laboratory in Belfast, Northern Ireland. So the methodology was very tight, and it was very standardised to International Federation of Clinical Chemistry, etc. But I think that is generally true. I mean, HbA1c obviously measures a different aspect of glucose metabolism than the glucose tolerance test values. And in general, it is less sensitive. It really picks up very few of the cases that we would classify as GDM using any other methodology, irrespective of where you set the diagnostic threshold. So I personally use it a bit in the early pregnancy because I think it hasn't changed much by then. But I think using HbA1c as a standard 24 to 28 week GDM test is really next to useless.
Yes, and can you see further questions?
A question about to avoid coming to hospital.
Yes.
It's about home glucose tolerance testing, I think. So that actually exists. There's at least in the UK, I've seen a pre-packaged big envelope essentially with a glucose tolerance test in it where the woman is able to do that at home. And it's been quite well validated, but I think it just hasn't achieved prominent status around the world. But from what I've seen, it looks very promising that there's a R equals 0.9 something correlation between those glucose values from the home test. So you get a sachet and mix up your glucose solution, you do your fasting test and your 1 and 2 hour test in the comfort of your living room, and that seems to work fine, but it just hasn't had much applicability around the world yet.
Okay. And now I'm actually losing a bit of track. Did you come to the question, when was the not promising HbA1 drawn?
Okay, I can see that. There's a question from Lena Ringholm in Copenhagen, I think. She's asking, do you think we're seeing more, it's a good question, do you think we're seeing more cases of GDM due to worse lifestyle in pregnancy with less exercise and poorer diet? Well, everyone talks about their COVID kilos or something along those lines. I think that is certainly a factor. We haven't really seen that. We've probably seen a bit less because, a lot of people in Brisbane, at least, have been doing this fasting first protocol. So I think we're probably seeing a bit less overall GDM, but our rates are still pretty high at around about 12 to 13%. So we haven't really, can't really promise on that one. And there's another question there about HbA1c drawn early. So I think there is certainly a number of studies looking at HbA1c in early pregnancy, and they're also not very promising in terms of prediction of GDM. So HbA1c in early pregnancy, we did use to, in an attempt to identify women who might need treatment from the early pregnancy stage. So we based that on the data by Ruth Hughes and company from Christchurch, New Zealand, where they found that if you had an HbA1c of 5.7% or greater in early pregnancy, your pregnancy was high risk, even if you didn't necessarily call it strictly GDM. But if you look then just at the, whether an HbA1c in early pregnancy predicts well a diagnosis of GDM later, it's not a very good predictor of the GDM diagnosis. But to me, it's important that it's associated at a level of 5.7% or greater with more pregnancy complications. But most studies would show you only pick up 20 to 30% maximum of what you'd otherwise call GDM using HbA1c.
Yes, thank you. Do you have more questions in your chat, David? Sometimes.
I think that's the last one I have.
Yes.
Yeah.
But do not hesitate to ask more questions or ask to be unmuted. Some of you might be writing a question right now, and I'm not able to see when you are writing in the chat. But while some of you might be writing, I will just open a poll, and I hope you will just answer the two questions so that we know a little about what you think about this webinar. But if you have more questions, do not hesitate to write them in the chat. Then David will give you a reply in a few moments. And thank you. Thank you for answering the poll. We really appreciate it. And we also appreciate all the questions that you have already been asking. Yes. It seems that there is.
I'll open the. I'm sorry, I wasn't looking at the chat there. I think that's.
No.
I haven't got any new questions at the moment.
You haven't got any new questions. I will just. Yes, there is one. Yes.
Okay, so the question is, do you think this discussion about GDM and COVID could be a chance to have more consistent criteria across countries, or is that not desirable? Do you know whether Canada or the UK are reconsidering their diagnostic changes? Well, I did hear from Denise Haig, who's one of the people in Canada just last week, that having listened to a similar presentation I gave for another meeting, she thought they had never really been absolutely unanimous. And in fact, Canada has a couple of different sets of GDM criteria. So they were thinking about revisiting what they're doing during COVID. I think the UK is a bit of an outlier, both in the way it tests and the criteria and the thresholds that it uses. And look, I'm not absolutely convinced. I mean, I started off 10 or 12 years ago thinking we should have one universal set of criteria for GDM. But now I tend to think, particularly with the Danish example, that you've got to be very careful about exactly what laboratory tests you're using, because particularly for the fasting glucose, as I said, there's a paper from a good colleague and friend of mine, Mukesh Agarwal, who's looked at this. So a small difference in glucose measurement, plus or minus 0.2 millimoles per litre, will give you a doubling of GDM or a halving of GDM. So you've got to be very careful that whatever protocol you're using is aligned as closely as possible to what was found in HARPO or to some other external set of validation criteria. And then you've got to remember that different ethnicities have different glucose distributions. And in Australia, we have quite a mixed ethnicity. So we have Asian women who have, in general, pretty low fasting values and higher 1 and 2 hour values. We also have Australian Indigenous or Aboriginal women who have more diagnoses on the 2 hour level. And we also have quite a few women from Arabic countries who mostly have high fasting levels. They don't have trivial high fasting levels because they do go on to later get type 2 diabetes and quite severe complications. So it really, I think there does need to be a bit of country by country modification. And the other approach that I'm personally interested in is using other risk factors such as maternal BMI and other characteristics to produce an overall risk rather than just talking about the GTT results by themselves. But I think this, the approach that we've taken in Australia of using a fasting test first, I think it does have some potential advantages in terms of saving on GTTs and the inconvenience that goes with them, and also taking out a group of women who, although we call them GDM on their 1 and 2 hour values, actually have a very low risk of adverse outcome. So I think there is some scope for using some of these criteria, evaluating them after COVID.
Yes, thank you. David, do you have more questions in your chat? Some might have.
I think that was the last one from Antonia, I think.
Yes, good.
That's the last one I have. Yeah.
I have no further questions in my chat. So I think I want to thank you for presenting your research, David, and thank you to Per Ovesen for giving a brief insight into the local situation in Denmark. And as we use the 45 minutes that we ask people to use on this webinar, I will end the webinar. Thank you to all of you. Thank you for joining, and thank you for all your questions. We really enjoyed that.
Hello to my many friends in Denmark. Nice to not see you, and I know you're there. Thank you very much.
We'll hope we see you in Denmark soon, David.
I very much hope so too. They just need some flights to be available.
Yes, I know. Thank you. Bye-bye.
Okay, thank you. Goodbye.